Good evening. Welcome to this case discussion. It was an interesting case with a little twist and turn here and there. Difficulties, practical difficulties. That's why I wanted Indraja to take the history and give a presentation. What I always feel a case discussion should contain is your capacity to think things out, get the appropriate investigations, institute the appropriate intervention. And when you're faced with a dilemma, use a logical sequence of decision making to do what you have to do. All right. And so that is what you will see here. And so, you will find that my clinics will be very different from what you have in an exam. In the exam, a lot of time is spent on, obscure signs and, how do you do this? So, I have no disrespect for clinical acumen, but, a lot of details, even in the RRC, that's what happened. But I believe that as a clinician, you must know the principles of certain tests that you do clinically, principles of certain tests, tests that you do in the laboratory, and take it up from there. Okay, so you will find that my clinics will always have a very practical kind of orientation to it. Let us see how you guys think things through in this interesting case. Over to you, Indraja.
Thank you, sir. Good evening to everyone. Today I am going to present a case of pain abdomen. A 75-year-old female homemaker came with complaining of pain abdomen since 15 days and also complaining of vomiting since 15 days. Patient was apparently all right 15 days ago. Then she developed upper abdominal pain, which was sudden onset, severe pain, colicky type, and radiating to back, which was not relieved with medications, with multiple episodes, which was bilious in nature. History of fever was present, one episode, and there was no history of hematemesis and melena, and no history of loss of appetite and loss of weight. Patient doesn't have any medical comorbidities, and she was tuberculosis 45 years ago. Personal history, sleep was adequate and appetite was normal, and there were patient doesn't has any allergic history to the drugs and food allergies. On examination, patient was moderately built and well nourished. There was no pallor, icterus, clubbing, lymphadenopathy, and edema. All the vitals were stable except pulse, mild tachycardia, that is around 106 per minute. Parabdominal examination showed tenderness in the right hypochondriac and epigastric region, and gauding was present, and some distension with free fluid was present. Other systemic examination doesn't show any abnormality.
Wait. No, go back. Go back further.
Yes.
Yeah. Can you please tell me, let's ask Praveen, is there anything else you would like to know in history? Praveen?
Sir, yes,
Not
sir.
here? You're here?
Yes, sir.
Yeah.
I'm present, sir.
Go on.
Sir.
Yeah. Go on.
Sir, any itching?
Itching. All right. Why do you want to know itching?
Sir, for any jaundice symptoms, sir.
All right. So you want to know if the patient was icteric, okay?
Yes, sir.
And the patient has itching. Why do you want to ask for that?
If any liver pathology is involved or not, sir.
No, do you want to ask for it for every case, or is it in this case that you're considering it?
In the abdominal cases, sir.
All abdominal cases, you want to ask for itching and jaundice. Yeah, not very common, but fair enough. But in the pain itself, is there anything else that you would like to know? She talks about relief with medications. Is there anything else that you would like to know? Upper abdominal pain.
Aggravated
Aggravating and relieving factors, right?
factors. Yes, sir.
But she has read
With
that, no,
food
she has
and
said one relief factor, one relief, which is no relief with medication.
exercise.
What are the relief you would like to ask for? This is, very basic stuff. There is no trick in this question. Any abdominal pain, upper abdominal pain, okay?
If it release after food, sir.
Yeah, relation to food, right? Is it better
Yes,
or
sir.
worse after food?
Food.
That has to be mentioned.
Yes, sir.
All right. And
Yes, sir.
if you have severe pain in the upper abdominal area, what else would you ask for? What would be the posture of a patient with, say, acute pancreatitis versus a PERV DU?
Bending forward
Yeah,
position, sir.
so you must ask, is there anything that gives you, apart from food and medication, is there anything else that you do in terms of your posture that would give you relief? Okay.
Yes, sir.
Girija, Indraja, you're noting this?
Yes, sir.
Yeah,
Yes, sir.
these points you have to mention for a complete history.
Okay, sir.
Okay.
Yes, sir.
And there is one other important point. If you must, once the patient complains of some pain somewhere, you must, at that point itself, entertain a differential diagnosis. So you're talking about a biliary colic, you're talking about intestinal obstruction, talking about pancreatitis, and a DU.
Yes.
So what
Yes,
would be
sir.
the characteristic pain of a DU?
Sir, it relieves after taking food, sir.
Okay. Anything
Relieves
else?
with it after food. It will start 3 hours after the food
Okay.
and relieves after taking food, sir.
Nocturnal pain, man.
No. Oh,
It's such an important thing. Does it wake you up in the middle of the night, 4 a.m., 5 a.m.? And when you have a drink of water and have a drink of milk, is it better? Okay, that's a classical feature. So when you describe pain in somebody, you have to include these factors for a
okay.
complete examination.
Okay.
And vomiting also. What other things would you like to have? Vomiting present,
Whether
multiple episodes.
whether
And you
any
said
food
it is
particles,
bilious. Okay,
yes,
okay.
sir.
What else should you include?
Any food particles is there or not?
Okay.
Whether it is projectile.
Yes, you didn't
Yes,
mention any of that, no?
yes, sir.
There are so many things that you have left out. You can't do that, okay? Even clinically and in an exam, you can't afford to do that. Whether
Okay.
it is projectile, how long after eating does that happen?
Yes,
Is
sir.
it immediately after eating? Typically, this patient said, the moment I have a few sips of water, I vomit. Is that pathological? No tricks in my questions.
Oh.
If you have a patient who has a few sips of water and she vomits, is that pathological? Most likely not. Okay, unless you have an upper esophageal obstruction. Such people will be spitting out saliva also. It's not just vomiting after fluids. Upper esophageal obstruction or a pharyngeal pouch. But this almost is, if you would consider it functional, if somebody takes a few sips of water and immediately brings out. Okay. What is
Yes,
more
sir.
often is what? Suppose they bring it out a few minutes, maybe a half an hour after food, and it has food particles. What does that mean to you?
Maybe gastric outlet obstruction.
Yeah, and if they have, you said bilious, so it's not gastric outlet, but it could still be gastroparesis. It could still be gastritis. And if somebody takes food and vomits maybe a few hours later, what would that indicate?
Any ulcers, duodenal ulcer.
No, small bowel obstruction. Food is gone beyond the stomach, but then, gastric emptying time is finished, and maybe an hour or two later encounters an obstruction, and so they vomit. Okay, so
Yes, sir.
these details of how long after taking food,
Yes,
what
sir.
is its nature, is it projectile, is it regurgitation, is it preceded by pain or not, and is that pain relieved after the vomiting? These are the points. So your history really is quite inadequate here. Okay, and as Praveen pointed out, you should have at this point, when there is fever, you must also ask abdominal pain, fever, and jaundice.
Recent history of jaundice.
Yeah. So you must ask about jaundice, whether it was at any time she's had that, and itching that he mentioned. That yes, that's also important. And while you mentioned about hematemesis and melena not being there, constipation can give you pain. So he didn't tell us about her normal stool pattern. Was it normal? Did she move her bowels normally? This patient, in fact, was moving her bowels normally, but
Yes,
that
sir,
has to
normal.
be specified in your history.
Okay.
Okay. Any other comments? Anybody? Any other comments? So your history has to be a lot more thorough than what it was in Indraja.
Okay, sir.
Okay. And
Okay.
go to the examination slide. Okay. What else is there anything else you would look for here?
For rectal examination.
Yes. Did you do
And
that? Did you do a rectal examination?
no, sir.
Yeah, it's not. Next time, do it. Nothing wrong. You
Yes.
ask for the patient and finish that. Okay. Anything else?
And supraclavicular fossa.
Yeah.
Yes, sir.
No, go back one slide. Yeah. So moderately built, well nourished. Is there anything else that you normally report here? Performance status is something people expect you to do.
Yes, sir.
Yeah. You can't leave these things, Indraja. Be very thorough about what you do. Okay. Performance status must be mentioned.
Okay.
All right. No pallor, icterus, clubbing, all that is okay. You're
Yes,
given the vitals and you've said that is normal. Okay, go on. In abdominal examination, right. Now, when you might put the positive things
Yes, sir.
in, we have done correctly, but when you report, you have to report a thorough examination in the form. I'm looking at an examination for you.
Yes, sir.
In the same pattern as you do in an exam. Inspection,
And
palpation, percussion, and
auscultation.
So please do
Yes.
not forget to do that. Position of the umbilicus, what is the status of the abdomen,
Yes, sir.
prominent veins, groin swelling.
Yes, sir.
All of that has to be presented when you present clinically.
Okay.
Okay, take these exercises as
sir.
an examination exercise.
Yes, sir.
Otherwise,
Okay.
if you do not have that habit in the exam also, you won't say that. And then people will haul you up for it. Okay.
Okay.
Remember
I'll
to
do.
do a thorough job of it.
Yes.
Okay. And next time, do that
Yes, sir.
and go to the next step. Now, at this point, let me ask the students. Okay, Pavan, what would you do here from here onwards?
Sir,
Okay, let me go back one step. If you've been listening to the story, give me a summary of the clinical history and findings.
sir, a 75 years old lady came with the complaints of pain abdomen since 15 days, sir.
Adella summary, pain abdomen and
Pain
vomiting.
abdomen associated with multiple episodes of vomiting
Yes.
and one episode of fevers.
Yes.
And patient vitals were normal,
Yeah.
apart from mild tachycardia.
Yeah.
And
Examination showed some upper abdominal right hypochondriac,
hypochondriac tenderness and
possible guarding with some free fluid.
yes.
Okay, at this stage, what would you offer? What is your diagnosis and your differential diagnosis?
Sir, my first diagnosis is acute calculus cholecystitis, sir.
Okay. Differential diagnosis.
And one more thing is,
why do you hesitate so much? Abdominal pain, vomiting, back pain, right upper quadrant.
any gallstone, pancreatitis.
You said it can be cholecystitis, pancreatitis. What else?
Pancreatitis.
And then ulcer disease, man.
Oh, yes, sir.
Would you not think of a duodenal ulcer in this?
Yes, sir.
These are the possibilities. So how would you proceed?
Sir, initially I will do blood investigation, sir.
What would you do?
So CBC I will do, sir.
Okay, go on. List the tests. Yeah, CBC.
CBC, RBS,
Yeah.
creatinine,
Yes.
serum electrolytes,
Yes.
and LFT,
Yes.
amylase lipase.
Right. Good. What do you expect in an LFT in this? What do you expect to see in that?
Sir, whether it is an obstructive kind of pattern is there or not.
Whether there is jaundice or not in the first
Jaundice is
instance.
there or not first.
If so, it is obstructive or hepatocellular.
Yes, sir.
Okay. What would you expect in amylase and lipase?
Sir, amylase is elevation, sir. Elevation.
Okay.
And lipase, lipase also will be elevated, sir.
All right.
according
Is
to
there a
this.
difference in the pattern in which these two elevations occur in pancreatitis? Suppose the normal limit of amylase, upper limit of amylase is 150 in your lab.
Yes, sir.
What should be the minimum increase in amylase before you label it pancreatitis?
Sir, at least 2 to 3 folds, sir. 3 folds.
Not 2, 3.
3 folds.
3-fold is what you have to do. So,
Yes.
do you see any difference in the pattern of rise in amylase versus lipase in pancreatitis?
Sir, if it is a acute severe pancreatitis, so there will be an increase in amylase along with lipase also will be elevated.
Will they both be elevated at the same time?
Sir,
Indraja?
I'm not sure.
Not sure. So it is an assignment for all the students.
Okay, sir.
All the books give you lovely patterns of when the amylase increases, when it reduces, when the lipase increases, and when it reduces. It has to do with the number of days of pancreatitis. I won't spoon feed you. All of you look at that, and also the difference between serum amylase and lipase and urinary amylase and lipase. Okay, that will also be increased. So you need to know what is that relationship. You do that and send the answers to me.
Okay.
Okay. What do you do next, Indraja?
Sir, after blood investigations, I would
Yes.
like to do the ultrasound abdomen and pelvis, sir.
All right. So what do you look for in the abdomen before you show our report? What do you look for in the abdomen?
As
You have a
patient-
differential diagnosis. So what do you look for?
Yes, sir. As patient is having right hypochondriac tenderness,
Yeah.
first I look for the gallbladder and liver, sir.
Okay. What do you
And
look for
then,
in the liver?
whether any obstructive pattern is there, whether any intrahepatic biliary radical dilatation is
Okay.
there. And
You
then
must start
I
with the
look for-
size, right? Being
Yes, sir.
surgeons, I didn't insist on you having this in your differential diagnosis, but a hepatitis is very much a possibility in this kind of symptomatology. Right upper quadrant tenderness, okay, guarding, and vomiting, pain abdomen, vomiting because of acute hepatitis, because of a stretch in the capsule, they get pain.
Yes, sir.
So hepatitis should be entertained. Calculus and acalculous cholecystitis should be entertained. What else in ultrasound?
Then I look for a pancreas, sir.
Yeah. Is
Whether-
ultrasound good to detect problems in the pancreas?
No, sir.
Not very, but anyway, you
not-
can sometimes get it. Okay.
Yes, sir.
Space occupying lesions in the liver. Okay. Next,
Whether any fluid is there in the
free
abdomen.
fluid in the
Free
abdomen.
fluid in the abdomen. Yes, sir.
Any other masses?
Yes,
Any other masses may be there. So these are the things that you look for.
yes.
And so please go to the next slide and show us what your report was.
Yes, sir.
Yeah.
Ultrasound abdomen and pelvis, which was done outside, showed cholelithiasis with acute cholecystitis and altered echo texture of the liver with moderate ascites and umbilical hernia. And all the blood parameters that were done are within normal limits. And patient was started on diuretics to control the ascites and oral cephalosporins because of the cholecystitis, and posted for laparoscopic cholecystectomy 3 days later.
Yeah.
Shall I proceed,
No,
sir?
no, no, no. We'll ask Abdul. Do I see any seniors here? I don't see any seniors here. So Abdul is a senior there. Okay. Abdul,
Yes, sir.
is what we did right? If so, if not, what is not right?
No, sir. I think we are also suspecting liver dysfunction in this
Okay.
patient.
Yeah.
So we are controlling the ascites, giving him, probably would have given vitamin K as well.
Yes, you're right.
And then we are, once the patient's coagulation is better, we are
Yeah.
planning a lab chole 3 days later.
Yeah. See, patient had PTINR was done, even though the LFT was normal, the altered echo texture warned us that there could be chronic liver disease. At this point, you have to do two things to know whether there is really severe CLD or not. What are those two things, Indraja? All practical issues.
Coagulation profile, sir.
Yes, PTINR was
PTINR,
normal and
no. And
serum albumin.
serum, yes, sir.
It was not low in this patient. Okay, so
Yes, sir.
if the PTINR is abnormal, it shows fairly severe compromise of overall liver function. So even though we were aware that this patient could have cirrhosis, we were not too worried because these two parameters, albumin and the coagulation
program.
profile, were normal. And as Abdul rightly said, we didn't, even though we knew it was acute cholecystitis, we didn't straight away take her up for surgery because we wanted to control the ascites a little better. So we gave her diuretics, 200 milligrams of spironolactone, and it did help her. And we got her back 3 days later. Next. Go on.
On the day of admission,
Yeah.
Repeat abdominal examination showed less distension,
Yeah.
and there was vague mobile mass palpable in the right lumbar area,
Yeah.
and the tenderness was persisting in the right upper quadrant.
Right. So at this point, what next? Right. At this point, because perhaps the ascites was better, or perhaps because we were not as careful as we should have been when we first saw her in the outpatients, we felt that there was a vague mass, even though it was not very obvious, a vague mass in the right lumbar region. Okay. Tenderness persisted. What would you do next, Abdul?
So, can I know how would the mass was, sir? Like
Very difficult to discern it. It's difficult. We felt that there's some fullness in the right lumbar region.
okay, not continuous with the subcostal region.
Not continuous with the subcostal. Really could not decipher its extent and all that kind of a thing, because even though ascites was better, some ascites was still there, and the tenderness in the upper quadrant, but there was this vague mass which was felt on deep palpation. Remember, the patient had gone home after the OPD visit and had come on the morning of a given day, and at midday on that day she was posted for surgery. What are my choices at this point, and what should I do?
Sir, either we can go ahead with the diaglap and probably put the port's lateral palmars point and visualize the thing, or we can go ahead and get a CT scan, CT abdomen and pelvis with contrast, and then after that, after the CT, we can decide.
What would you do?
So size of vague mass, intra-abdominal, probably rule it out before you go in. So get a CT scan.
What would be the advantage and disadvantage of a CT scan in this instance?
So probably malignancy could be ruled out.
Okay.
And whether exactly the mass, whether it is renal mass or what, we don't know exactly.
Okay.
Or it could be just a mesenteric cyst as well.
Okay.
So exact picture will come to know by a
the CT. What would be the disadvantage of doing a CT?
So nothing as such.
Nothing as such, except that you're delaying it maybe perhaps by a day.
Yes, sir.
All right. And so what we did was that because the patient was still tender in the right upper quadrant, we discussed this with the family and said we would go ahead with the gallbladder operation. have a look at this mass, okay, whatever it is that we are feeling, and also said she might do something, she might need something else if this CT scan that we're going to do in the post-op phase would show up something. Okay. We explained this to this family, they agreed with our plan, and so we went ahead with surgery. Go on, Indraja.
Yes, sir. Sir, is there any role of fluid analysis in this patient, sir?
Yeah. See, the patient definitely had acute cholecystitis, calculus, not even acalculus. If it was acalculus, I would think twice before touching the patient.
Yes.
And so we didn't think that fluid analysis, and mind you, the ascites had come down quite a bit,
Yes,
and
sir.
so it was not easy to get the blood. So we did not have malignancy, the to diffuse malignancy as a possibility here, and so we went ahead with what was significantly symptomatic, and that was calculus cholecystitis. Go ahead.
Yes. Intraoperatively, there was nodular liver query cirrhosis and about 200 to 300 ml of free fluid was noted.
Yeah.
And there was incidentally diagnosed nodular mass of size approximately 5 into 5 centimeters, query arising from the retroperitoneum in the para-aortic area.
Yeah.
Para-aortic area, and the peritoneal cavity was normal. There was acutely inflamed gallbladder with edematous wall with adhesions covering the lower 1/3 of the gallbladder.
Okay, next slide. Okay, so when you find these findings, I think we should have a discussion with perhaps some of our guests. Shabir Pasha is a name I see. Can you unmute yourself and introduce yourself, please?
Yes, sir. Good evening, sir.
Good evening. Tell me, Shabir, where are you? What are you doing?
Sir, I am from WIM, sir. Final year student, sir. Surgeries.
Okay. Okay, very good. And
Yes.
I see another guest, I think, what's his name? Did I say Guru Raj? Can you unmute yourself as well, Guru Raj? Are you there, Guru Raj? Yeah, as he's unmuting himself, maybe he's not even there. Shabir, tell
Sir.
me, at this point, you put a laparoscope in, and
Yes, sir.
there's an acute cholecystitis, adhesions. I know I'm going to take it out. And as I was exploring the abdomen laparoscopically, not laparotomy, laparoscopically, and while I didn't see any big mass or anything on the bowel itself, when we shifted the small bowel away and looked at the mesentery, we found a nodular mass in the para-aortic area. Okay. What
Yes,
would
sir.
you do at this stage?
Mass, no.
Say something, don't keep quiet.
Yes,
We
sir.
all make mistakes. So there's nothing wrong in it.
Parietic
Question of
lymph node.
okay. Now
Maybe lymph node and
okay. First question. What would you be doing with the gallbladder?
gallbladder cholecystectomy.
So what would you do with the mass?
So we'll take a biopsy of the mass.
Okay. Is there any advantage? Disadvantage obviously is that you will get a diagnosis.
Yes,
Any
sir.
disadvantage of doing a biopsy there?
As such, no disadvantages, sir.
No disadvantage. All right. If you do not do a biopsy, what would be the consequences?
You may be missing if it is a malignant or if there is anything.
No, but we have, remember in the pre-op phase, we have explained that we need to, there is a mass, if that is confirmed, this is vague clinically, but if it is confirmed, I would do something else later, which may include even another procedure. This has been explained and an informed consent taken from the family.
Yes, sir.
Yeah. So what would you do in that situation?
you might take just biopsy and you can come out, sir, or
Okay.
later on you can plan for next.
All right. Okay. So in fact, I didn't even take a biopsy.
Okay.
Why would I not do that? Now, if you have a para-aortic mass, which you rightly said is a lymph node mass, what are the possibilities there? Tuberculosis, yes. Why are you hesitant? You're a third-year student. Get on. You get on with it. And also, I'm not looking at rare disease, common things that you see. That's
Common
what.
thing. Yes, sir.
Tuberculosis. Could it be a lymphoma?
Yes, sir, the possibility.
Could it be a retroperitoneal tumor?
Tumor. Yes.
Huh? Those are the three things.
Yes, sir.
Now, if the only situation where I could have avoided another procedure would be tuberculosis and lymphoma.
Yes, sir.
If the CT told me something, okay, and which was not a malignancy. I mean, if it's a malignancy, not a bowel malignancy,
Yes, sir.
okay, then I could have said I'll not do anything. So biopsy was very seriously considered, but we felt that even before I put a knife into that, did a biopsy of that lesion, I would like to know whether it is a retroperitoneal tumor or whether it is a bowel tumor, which
Yes,
we have not really felt on laparoscopy, which is not obvious, or whether it is something else. So we said, if it is something like tuberculosis on CT, it was a simple enough thing to do a CT guided biopsy
biopsy. Yes.
to get histology. So we did not want to do anything at that point in time. I'm sure, others would say, other surgeons, and quite correctly say you
Yes,
should have done a biopsy. But because we had ways and means of diagnosing it even without biopsy at that particular time, we noted the findings, noted that we would get a CT post-operatively, and then finished the lab call and came out.
Okay.
Okay.
Yes, sir.
Yeah.
Yes.
But I concede that somebody else would say you should have done a biopsy. But we were confident that this is a lesion which can be, when confirmed on CT, one could have easily done a CT guided biopsy for that.
Biopsy.
True cut
Yes.
biopsy. Yeah. Okay. Go on. Next,
Yes.
Indraja. Yeah.
And family, it has been explained about the incidentally diagnosed right retroperitoneal and
Yeah.
need for further evaluation.
Yeah.
And the patient was discharged and advised with CT abdominal and pelvis.
Yeah.
And on the day after discharge, patient has undergone a CT, which showed there is thickening of the
Oh,
sphincter.
no. Stop.
Yes, sir.
Just don't be in a hurry. Okay. No. Put the CT pictures. I was just trying to see if can you see when you put pictures, these names must be covered.
Okay, sir.
Can you see this? This should never happen. The patient's identity should never be seen in any CT that you put publicly. Okay.
Sir.
Please remember
Okay.
that always. You can put a little black square on it.
Okay.
So that
Sure.
everything else is okay, but that should not be there. Okay. Now,
Yes, sir.
can somebody read this? Guru Raj, are you there now? Not there. Sanya, please introduce yourself.
Good evening, sir.
Good evening.
I'm a third year student from WIMS, sir. Actually, there has been a spelling mistake, sir. It's Sahana, sir.
Sahana. Okay. All right, Sahana. Can you read this CT for me, please?
Yes, sir. The first one is a coronal section, sir. The other two are transverse sections
Correct.
of a contrast enhanced CECT abdomen, sir, and pelvis.
What contrast has been given?
There have been like markings.
What contrast has been given?
The venous phase, oral contrast.
Does venous
oral
phase?
and IV, sir.
Correct. Both oral and IV have been given. And yeah, can you read this now? Can you read the first picture? Yeah, go on. I can hear you. Please go ahead.
Hello, sir.
Yeah, go on. Can you not hear me?
Yes, sir.
Indraja, can you hear me?
Yes, sir.
Yes, I'm
Okay.
able to hear you.
Sahana, go ahead. Read this
Yes, sir.
CT.
Sir, oral and IV contrast have been given, sir.
Okay. You can't, yeah, one of them is a coronal section, left upper part. The other two are transverse. Okay, go on.
Yes, sir.
Do you see something in the right iliac fossa?
Yes, sir.
What is it?
Like a mass, sir.
Yes. Where do you think that mass is from?
Probably ileocecal junction.
Yeah, somewhere in the cecal area. Okay.
Yes, sir.
If you see a mass there, what else should you see? What else should you look for? What are the consequences of an ileocecal mass? Just think about it. They're all very simple. Yeah, go on. Can you hear me?
Sir, I'm not able to hear you.
Indraja, are you able to hear me?
Yes, sir. Yes, I can.
I don't know why she has a problem.
Sir, the audio is not here.
All right. Okay. We will just, I don't know. You may not be able to hear me.
Yes, sir. Now I'm able to.
You can hear me. Just say, yeah. See, when you see an ileocecal mass, be it, what are the things that go through your mind? What are the ileocecal masses that you know of?
Sir, first one is a TB, sir.
Okay.
Tuberculosis.
Go on. Just list them. This is how your mind must work when you see a case. That's why I'm trying to help you through that process. Yeah.
Crohn's disease, sir.
Crohn's, very rare. Okay. Ulcerative rather than mass lesion. Okay. Tuberculosis.
Yes, sir.
All given in standard books, no? Amoeboma. Rarely actinomycosis. So
Yes,
when you have a mass lesion in the ileocecal area, what are the other things that go with the mass lesion in these diseases?
Appendicular mass.
Appendicular mass is definitely possible. Okay. So what are the other things that we have listed the disease? What are the effects of this kind of mass? What are the other things that go with it? We now know about the mass. So when you're reading a CT, you must look at what are the effects of that mass in addition to that mass. What are the effects? Can it cause obstruction?
Obstruction, yes, sir. Distally, it should cause obstruction.
Sorry?
Distal to the lesion, there should be obstructions.
How can they be distal to the lesion? Obstruction is distal. There must be proximal dilatation.
Proximal, sorry, yes, sir. Proximal to the lesion.
Yeah, it cannot be distal. So you must have proximal results of an obstruction in ileocecal region. What does it do proximally?
All bowel obstructions.
Yeah. So what do you find on obstruction on CT?
Air fluid levels.
Air fluid. What else? Does it become big?
Edematous bowel wall.
Distension, man. Not even edematous. It could be edematous. There must be distended bowel. Do you see any obvious distension here?
No.
No, except for this one little bit. I'm not able to see the pointer. Indraja, show the pointer just below and to the left of coronal section, below and to the left of the mass. Coronal section, you're seeing the transverse section.
Sorry.
Yeah, below and to there. Yeah, that is a bit of a distended bowel, right?
Yes, sir.
It doesn't look normal. That's probably ileal loop. That is the mass just above and to the left of that, left as you see. And what else do you see in the para-aortic area? Do you see a lot of blobs in the para-aortic area that you don't see elsewhere?
Yes, sir. Probably lymph nodes.
They're all lymph nodes. Similarly, lymph nodes are all very nicely seen in the transverse section as well. You can see the aorta, you can see the IVC, and around it, you can see a lot of lymph nodes. In fact, this is what we had initially seen in the laparoscopy. Okay, that's what we had seen. So while there was no obvious, gross, there may be mild gross obstruction of the small bowel, there was definitely an ileocecal mass. And clinically, if you went into the history, vomiting was a prominent symptom. So with these findings, what would you do next?
Work up further to
what
rule
is the
out
workup?
TB.
To rule out, what would you do?
Sir, we can send ascitic fluid analysis, sir, for
Okay.
AFP.
Okay. Okay. Anything
Then
else?
CT-guided biopsy of the lymph nodes.
All right. Yeah, something even more easy and more definitive than both of these.
Hello.
Yeah, go on. Something that you can do which will definitely give you a diagnosis. At least you hope it will. Yeah.
Hello.
Yeah, go on. All right. There's some problem with
Hello.
your audio. I hope you can listen to the rest of it. Shabir, you come in, man.
Sir, colonoscopy.
Ah, thank you. Okay. So what is much more definitive and easier than all these? I mean, nothing wrong in doing an ascitic fluid tap and sending it for tests and all that, but or a CT, but much more obviously done is a colonoscopy. Okay, next slide, Indraja. Okay,
Shall
this
I-
was go on, read up about it.
And CT showed thickening of the wall of the cecum with ileocecal wall with adjacent colon measuring up to 2.45 centimeters thickness and length up to 9 centimeters with a luminal compromise. And there was adjacent thickening of the peritoneum in the pericecal periileal area. And there was pericecal left para-aortic, pre-aortic aortocaval and porto-aortocaval lymphadenopathy was noted, and there was minimal ascites.
Yeah. What does fat stranding mean to you?
The inflammation in the surrounding
Yes. Inflammation and edema.
edema.
Okay, that's what
Yes.
gives you fat stranding. Normally, how does fat look on your CT?
Hypothyroid.
Huh? Sorry? Does it look white? Black?
No, sir.
In between?
Hypodense.
Hypodense, correct.
Yes.
So hypodense means more black than white.
No. Yes, sir.
So it looks like a gap. If you're talking about pancreas, for example, when there is pancreatitis, in a normal pancreas, there's a nice line which is peripancreatic fat, whereas that line becomes hazy with edema of pancreatitis. Apart from the swelling of the pancreas, you get a haziness around the edges of the pancreas, which is fat stranding. Okay, it denotes inflammation and edema of the tissues. All right, so go to the next slide. So we did a colonoscopy on this, but before that, yeah, say this. Yeah, go on. What happened?
On second day of discharge in the night, patient developed continuous multiple episodes of vomitings. Hence, she was brought to emergency and admitted in the hospital. On examination, all the vitals were stable. And per abdominal examination, there was the distension was present. Hence, patient was kept on nil per oral, started on IV fluids, and Ryle's tube was placed, and colonoscopy was planned.
Now, when
Yes,
the
sir.
patient comes back like this on second post-op day
Yes, sir.
of lap chole, what are the things that go through your mind?
Maybe there could be paralytic ileus also, sir, because
Okay.
she has continuous vomiting.
Okay.
Mm.
Electrolyte
Hence,
disturbance and ileus. Okay.
mm,
Pain was not a major
Pain.
feature. Vomiting was the main thing. Yeah.
yes,
Okay. See, you must really be thinking about lateral thinking, and you must always, these are all clinically important. So you must know one of them is a paralytic ileus.
yes, sir.
Paralytic ileus, perhaps because of electrolyte disturbance. Next, is there anything else that can give rise to paralytic ileus? Some kind of a bile leak
Yes, sir.
or a bowel damage, something like that, which could do that. Okay. What
Yes, sir.
else? We have discovered 2 days previously a para-aortic mass.
Yes, sir.
Could that
may
give any
cause-
obstruction, anything? Could that give obstruction to any structure that can cause severe vomiting?
It,
So we looked at two, basically one, it's not even two. One feature that could be directly related to the surgery, that is a bile leak.
yes, sir.
She was not pale, she was not hemodynamically unstable, so bleeding is not an issue. So bile leak is a possibility you must have in mind.
Yes, sir.
You may have electrolyte disturbance, and that could cause that. There could be obstruction. Obstruction can be, where can it be from? It could be from a para-aortic mass, which we appreciated. What structure would that obstruct? The duodenum.
Yes.
Okay, it can obstruct D3 or D4. That is, I had in mind. Did we miss this? Had we not seen it earlier? That's one thing I had in mind. And of course, at that point in time, we were not sure of the ileocecal mass, but it could be still. Remember, we had the CT later. Even though discussed it earlier, we should have actually mentioned about this admission before discussing CT. Anyway, so it could still be a bowel obstruction that could cause this. Okay, so these are the things that go in mind. So straight away we gave her antibiotics. She was on what was she on?
Magnexport.
Magnexport, which is a specific, that's a cephalosporin, which is very good for biliary system. So we had Magnexport IV. We gave her symptomatic treatment, IV fluids, NPO. Okay, and then did she have any other tests done at that time?
Electrolytes was done, sir.
Okay. Did she not have an ultrasound done?
No, sir.
Not ultrasound was not done. Okay, so we probably did not suspect it. It would have been nice to have it, even though I wonder why we didn't do it. But abdomen was pretty soft, and I was not in town at that time. My team was looking after her, and anyway, so abdomen was soft was what was reported to us. So we were not worried about it, and that's why. Oh no, sorry. I think CT scan was done before this admission or after this admission. I'm getting a little confused. Do you know?
Before, after the discharge.
Oh, okay, fine. Okay, then our order is right. So I was incorrect in saying, yeah. So after the CT scan, she developed this vomiting and all that.
Yes, sir.
Okay, fine. So clinically, even though she had vomiting, she was stable, no tachycardia, no sepsis. So we decided we'll just keep her, give her some supportive treatment, and do a colonoscopy. Okay. The next question we had in mind was whether we should give her preparation for colonoscopy or not. If you're suspecting bowel obstruction, would you give colonoscopy? Sorry, preparation for colonoscopy. Pavan, come in, man.
Sir, rectal enema we can use.
How do you give a rectal enema, and how far up does it go? Is it a replacement for oral preparation?
No, sir.
No. And where are we suspecting the pathology here?
Sir, at the ileocecal junctions.
Yeah, so you need to go all the way to the right of the colon,
Yes.
right?
Yes,
so if you give an enema, how would it work? But that is the next question. But right now I'm asking you, would you give an oral preparation or not?
Sir, no, sir.
No, agreed. When they suspected obstruction, bowel obstruction, for whatever reason, giving an oral preparation will not work. It will only worsen her vomiting. So you talked about rectal enema. So how is an enema given? None of this is theory. You have, as a resident, as a surgeon, you have to instruct your nurses as to clean the bowel when you cannot give the oral preparation. How do you do it?
Sir,
you don't know, you don't know. Let us not procrastinate. How much fluid do you give in an enema?
Sir, 275 ml, sir.
All right, some 250, 200, 250 ml. How long would you hope to clear with that if you do that?
Sir, I don't know, sir.
Not more than sigmoid colon. But yes. I want the right colon washed out. So how do you do it? So you don't give a rectal enema, you give a rectal washout. What is the difference between the two? Shabir, you want to come in?
Yes, sir. Sir, rectal wash through Riles tube and with...
not at the... We decided that the patient has suspected obstruction, Shabir.
Yes.
So nothing through orally, either Riles tube or per oral. You're not giving anything because that's not going to work. There is an obstruction. She's vomiting like mad.
Yes, sir. Rectal wash.
But you still want to see the right side of the colon. with a colonoscope. So instead of an enema, we said you give a washout. So what do you do?
So rectal
Indraja.
wash.
Indraja.
Sir, we can give bowel wash, sir.
Yeah, how do you do that?
Bowel wash, it has a catheter, so we have to introduce a catheter
Okay.
transanally, and we can give normal saline wash.
Yes,
sir,
how
for
much
that
do you
one.
give?
We can give up to 300 to 400 ml.
That doesn't work. You have to give a liter to liter and a half. That was the point I was trying to teach. Okay. So you have to give a lot of fluid. This lady had, I think, a liter and a half of normal saline, not in one go, but in 3 to 4 goes the previous afternoon.
Oh.
Okay. So we gave her a lot of washout and we were hoping that things would look well. We would manage to see the right colon. And as it happened, we did see the colon on colonoscopy. Show the next slide, please. This is the colonoscopic picture. It is the ascending colon, distal, proximal ascending colon. We're going other way. And you see, this lumen is now reduced to a little slit to the right lower part of your field. Okay. It was an obstructing growth. And you can see that we don't see an ulceration here. Okay. Does the mucosa look intact to you or it's not intact?
Yes, it is intact, sir.
It's intact. So
Yes, sir.
what would be the outcome of a biopsy if you take a biopsy from this? Bhavan. Go on, Indraja.
Like we don't get any definitive results, sir. The chances of coming negative also will be
Are high. Correct.
Yes.
Because you'll probably, the tumor is submucosal and you're
Yes,
probably
sir.
taking a bit of the mucosa, which may or may not show the positivity in the biopsy. Sahana, are you now, is it audible? Can you talk now?
Yes, sir.
Go on. So what is the solution for this? You're doing endoscopy. I think all surgeons must be endoscopists, but many are not. But anyway, I was doing the colonoscopy. This is the picture I see in the, cecum ascending colon area. And I find that if I take a biopsy, it may not be possible. So what should I do?
Sir, multiple biopsies must be taken.
Where from? You're right.
From the same point, sir. So
Exactly. Correct. Good. So what is that technique called? It's called the well technique.
Yes.
Well, you're going deeper and deeper in the same spot. So we took 4 biopsies, one after the other, in the same spot and went deep down. And still it didn't give us a positive answer. Okay?
Yes.
They said they could not find anything other than perhaps mild dysplasia. Even that, the pathologist was not sure. Okay?
Yes.
So at this point, what would you do? Go to the next slide, Indraja. Okay.
Yes.
Chronic colitis with reactive
Colitis
changes.
with the reactive changes, sir.
No granuloma, no malignancy. So at least you probably know that it is not tuberculosis. Okay, what else could it be now? It could be a cancer, adenocarcinoma. It could be a lymphoma.
Yes.
Other very rare diseases are something which will not discuss with any great detail, or they're all very, as I said, I focus on very common things. So it's either an adenocarcinoma or a lymphoma. What would you do now?
Sir, as patient is in acute obstruction.
Yeah.
Better we have to go for the surgeries.
Yeah, I would agree with that. What would you do? What surgery would you do?
As mass is located in the IC junction, near the IC junction and proximal ascending colon. I'd like to do the right-sided hemicolectomy, sir.
Right. How would you approach it?
First, I will do through the laparoscopy. We can do through the laparoscopy.
Correct.
Laparoscopic assisted.
Yeah. Try a laparoscopic assisted and always consent the patient for a possible conversion to open.
Yes.
Okay. So what we will do now, you see, this is a definite mass. It doesn't even look very small on colonoscopy or on CT. So the questions arise if you have, difficulty in detecting clinically a mass even of this size. Several questions arise. How important or how accurate is an ultrasound in picking up a bowel mass? Okay, that's one. And what are the other limitations of the other investigations that we do? Okay, to that end, we will, Indraja and I have worked on certain data, on certain papers, and we will share that knowledge with you. And in the end, I'll tell you what we did because we operated on this lady today. Okay, go on, Indraja.
Yes, sir.
Yeah.
According to a study conducted by Johnson et al., they studied about the sampling errors followed by the colonoscopy. So it was a retrospective study. They studied about almost 962 patients who underwent elective colorectal surgeries, and they compared both the final histopathology and flexible endoscopic biopsies, and they said the sampling errors were occurred in about 217 patients. And they said negative biopsies were associated with longer median time to surgery compared to the true positive biopsies.
So essentially, it means that in about 22% of cases, you may not get a biopsy result. And the consequence of that is that you don't operate early enough because it is negative. You want to go in again and do it that way, which may or may not be done. I have always practiced that if I do not get a positive biopsy, I would have told the patient well in advance that, look, sometimes these things happen, 1 in 5 cases. And so the best thing is that we need to operate and take it out. So that is the way I go. Very rarely, if you find it's a small lesion where a surgery may not be required, or a very large lesion which needs neoadjuvant chemotherapy. Without histology, they will not give you, you're not justified in giving neoadjuvant chemotherapy. So in these two situations, we do repeat biopsies, okay, where surgery is not otherwise required. But otherwise, in the most cases where surgery would be indicated, I do not believe that we have to delay the surgery by another week or 10 days just to get a biopsy. So please note that 1 in 5 endoscopic biopsies can be negative even when you strongly suspect a neoplasm. That is the message. Next.
And despite of the advance in imaging techniques, many surgeons will encounter unexpected findings during the surgery. So it is a hard challenge to the surgeon in view of operating technique, and instruments also might differ. And we didn't take the consent for the new procedure by the patient and attendant.
Yeah, this is the important thing. Okay, so you can take a biopsy, you can do this, you can do that, but you have not consented the patient for all this. And so one of the things is you have two options at this point. Talk to the family, take their confidence, and then say, I'll do this even though I have not consented this before. And so that's one point. Or the other approach is, let us play safe, do what we are consented for, and then talk to the patient and do another procedure if required. Okay, that is those are the two approaches here. But the point is that in spite of several, in this particular case, we had not done a CT pre-op, the first operation I'm talking about. We could have done it as we discussed on the morning of surgery. We could have deferred surgery and done a CT and then gone on, even though I believe that I would still have, I would still have done the cholecystectomy because she was still tender and she was still symptomatic with it. Whereas imagine a situation where if I had done a CT, that would delay it by a day, and then that raised some issue and I would have had to do a colonoscopy that would put things off by another 3 days. If that happened, then I would still be sitting on a hot gallbladder, which would have worried me. So based on that, we went ahead with the surgery. But as I said, some other surgeon quite correctly also would have said, I would have done it the other way. I think both are correct. There's a chat box question saying, what is the role of CEA? Now, Sahana, you tell me, what is the role of CEA here? We have sent for a CEA after we did the colonoscopy, which showed me that there was a colonic mass. But before that, how would it matter?
Sir, it is not very sensitive, sir, but usually used for recurrence, sir.
Correct.
But
That is, you hit the nail on the head. So it is not something that is very sensitive or reliable as far as accurate as far as the diagnosis is concerned. But once you have a histological diagnosis of colonic cancer, then you can do a CEA, note its level, and once you resect it, the CA level should come down and you use it as a marker for recurrences. Well before you see macroscopic recurrences of the disease, you may be able to see a rise in the CEA, which would sensitize you to do tests or imaging studies more rigorously. Okay. So this patient did have a CEA. I don't know its value. Do you know what the value was, Indraja?
No, sir, actually, Nishant sir. I asked Nishant sir.
Huh. Yeah, I'm sure she has had a CEA, but it was not done.
It was sent,
Yeah,
sir. It
yeah.
was sent.
So we did it as soon as we did the colonoscopy. Okay, and maybe we've not got the report yet. That's one of the possibilities. Yeah. So CEA should be considered, but it's not for diagnosis of the prime or the first time diagnosis of the disease, but for monitoring the possibility of a recurrence. Okay, go on, Indraja.
And bowel ultrasound examination is safe and widely available and non-invasive imaging technique, and it allows the examination of the intestine without use of ionizing radiation, and it can be performed at any time. But the limitation of ultrasound is that detection rate is related to the awareness and technical operation and the experience level of the gastrointestinal tumor sonographer. And the comprehensive level of ultrasound doctors affect the detection rate.
Basically, it is very observer dependent.
Observer dependent.
That
Yes,
is
sir.
what it is. Machine dependent to some extent, but even more so, observer dependent. So, in the diagnosis of colon cancer, go on.
Yes, sir. And the sensitivity of ultrasound in diagnosing the colon cancer is about 79%, and the specificity is 92%. And positive predictive value and negative predictive value is about 80% and 91% respectively.
Yeah. So essentially, you may miss the diagnosis of a colon cancer on ultrasound in about 20% of cases. Okay, that's what it means. And this one was one such thing, because the tumor was not that small, and you would normally, as the CT image showed you, you would think
Yes.
that ultrasound would pick it up, but it is quite easy to miss it. And that's the take home message. So we as surgeons must be sensitive to that fact, that ultrasound can miss even sizable bowel masses. Okay, go on.
Okay. And the greater disadvantage is it is more observer dependent, and factors which are making the visualization of gut difficulties, lack of patient's cooperation, and sometimes body habitus like obesity and spinal deformity and presence of intraluminal gas.
Yeah.
And in this case, patient also is very obese.
Was obese, yes.
Yes, sir. Yes.
Yeah.
So that may be the cause also.
Yeah.
Yes, sir. And sensitivity of CT in detecting the colorectal cancer was about 100%, and its specificity was 95%. The positive predictive value is 33%, and negative predictive value was 100%.
Yeah. So what it means is that it is very unusual for you to miss a diagnosis of colon cancer on a contrast enhanced CT. Okay.
Yes, sir.
So
Yes.
compared to the ultrasound, CT is a much more sensitive investigation. Okay.
Yes.
Go on.
And according this study, they said like they studied about 96 patients. Of this, CT showed suspicions of malignancy in 96 patients. Of these 6 patients, all the patients were underwent colonoscopy. Followed by colonoscopy, 6 patients. I think I'm in confusion.
You're in confusion. Just read up. You'll get. Yeah.
Yes,
go
sir.
on.
On all the 96 patients are underwent CT, sir. Of these, 6 patients were suspicious of malignancy. Among these patients, all the patients were underwent colonoscopy. 2 patients were confirmed with the diagnosis, sir. And 4 was false positive.
Yeah.
Yes, sir.
So where is the confusion in that?
Initially I said wrong. But...
Okay. So if on colonoscopy, Okay, 96 patients had both CT and colonoscopy.
Yes, sir.
The 2 positives and 2 true positives and 4 false positives, which means CT said there was a cancer, but there was no cancer on colonoscopy. The value here of this is that false negative things were not there. Okay, that means the CT did not miss a tumor that was there.
Yes.
And that's a very reassuring thing. Just like in an ultrasound, it missed a tumor that was there. False negative, and that was not there in a CT.
Not there in the CT.
Okay, go ahead.
Sir, I kept 2 days images, sir, operative images.
You got that, yeah. So what we did was to do a attempted a laparoscopic hemicolectomy, and we mobilized the colon, but we found that it was really stuck because of the lymph nodes in the para-aortic area. We could not deliver the bowel, even though we mobilized it, we could not deliver it onto the surface. As you know, in a laparoscopic assisted colectomy, we mobilize the whole colon and it will come out of the abdomen, and we do the resection anastomosis and then put the thing back. The second thing that was deciding whether this was a 10 centimeter, you can measure it here. See, from here, the tumor is from there to there. Okay, it was more than 10 centimeters. No, it was about 8 centimeters, not more than 10 centimeters. It was about 8 centimeters or so. And it was, we could not take it out through a 2 or 3 centimeter incision. That's what we normally do for tumors. This is a very bulky tumor, and we had to make a big cut anyway. So we converted it into we had put a transverse incision. We didn't do a midline, transverse incision, and then extend that incision, kiffalad a little bit. So it was a curvy linear incision. Use that to mobilize the way we wanted it to. And because of the bulk of the para-aortic disease, 75-year-old lady, chronic liver disease, we did a conservative resection. This was not a radical right hemicolectomy. It would not make any difference to the, it would not have made any difference to the outcome of the patient. And so we did a conservative hemicolectomy, did a primary anastomosis, and came out. Okay. So Abdul has 2 questions. Does ascites affect ultrasound? Normally, no. Fat and gas does. Fluid actually gives you a window where you can see structures better. If laparoscopic biopsy of the lymph node had been done, will neoadjuvant chemotherapy play a role? A very good question. Can you think of 2 reasons why this would not work in this patient? And that is why we, even though we actually debated, I and Nishant discussed it at some length at the first laparoscopy and decided against it. Can you think of 2 reasons why that would not matter, Abdul, yourself?
Maybe, sir, we didn't find a mass beforehand. So
all right. No, but even if you did find a mass, it would not have made any difference to my decision. 75-year-old.
Yes, sir.
Okay, there's a big lymph node mass. That's what we detected. Rather, remember I mentioned we detected the para-aortic mass rather than the bowel mass, even at laparoscopy. Chronic liver disease. How well would she take a neoadjuvant chemotherapy?
Yes, sir. She won't be able to.
Number 1. Number 2, what was the other important thing that we have discussed all along? Patient was in obstruction, right?
Yes,
yeah.
sir.
So our initial thinking was that her vomiting was from cholecystitis, pain and that. And we did a gallbladder. She goes home and comes back in 48 hours with obstruction again, with vomiting again. So the patient is in obstruction. So this person is not a suitable candidate for any kind of delay in relief of that obstruction. As you can see, you see the cut edge of the specimen where that pointer is. What a tight stricture it is. There's nothing that's going to go through that. You cut it and you can see the difference, the normal bowel and the stricture. Okay, so for those 2 reasons, neoadjuvant treatment really was not an option for this patient.
Yes, sir.
Okay, yeah. All right, I think it's an hour and 5 minutes that we discussed. Any other questions, doubts, or anything else from the students, please?
Sir, when you on the day of admission, when you found there was a vague lump in the abdomen, what was your thought, sir, at that time?
My thought that it was a retroperitoneal tumor. And I felt that that's probably asymptomatic, that we have just found there, and her real symptoms were from the acute calculus cholecystitis. That's why I explained it to the family and went ahead with the cholecystectomy.
Sir, and one more thing, sir.
Yeah.
Before 15 days, she was completely normal. She doesn't have any symptoms.
Correct.
And she came with upper abdominal pain and vomitings.
Correct.
Immediately after the surgery, she went into intestinal obstruction. Before, she doesn't have that.
No, even before that, she might have. Even now, we don't know whether the vomiting that she came in with was because of this bowel lesion or whether because of the gallbladder.
Okay.
We still don't know.
Okay.
Both could have caused it. Yeah.
Okay.
Yeah.
Okay.
Okay. Fine. Thank you very much for coming on board. And tomorrow, I think we have a discussion on intravenous fluids, and Nikita is doing it. Okay. Thank you and good night.
Hello.
Thank you, sir.
Hello.
Thank you, sir. Good night.
Go on. There's some other question there. Sorry.
Sir, can we clinically differentiate retroperitoneal and peritoneal mass?
Very difficult. Very difficult. I know in the exams, people ask you about this. So we might discuss it now. Now that you've asked the question, what are the different clinically? I'm talking about differentiating factors between an intraperitoneal and a retroperitoneal mass. As you understand, you tell me yourself, Vinod. You asked the question, right?
Yes, sir. Yes, sir.
Yeah, go ahead. Just whatever you know from your studies.
Actually, it will. I learned it as these retroperitoneal masses doesn't move with respiration. Peritoneal masses will move with the respiration, but I don't find anything clinically.
No. It's not just with respiration, just mobility.
Yes, sir.
See, there are two aspects to mobility of an intra-abdominal mass. One of them is inherent mobility. The other one is mobility with respiration. Mobility is respiration occurs when it is somewhere associated with the diaphragm, either directly or indirectly. It may be direct association is a hepatic mass or a splenic mass. Okay, or indirect association is it's a mass which is closely not from the liver but closely adherent to it.
Yes.
Okay, and it is freely mobile in the peritoneal cavity. Retroperitoneal masses are fixed, so they do not move either inherently or with respiration generally, unless they are pedunculated. Very rarely you get pedunculated retroperitoneal masses which may move. And intra-abdominal masses not associated with the diaphragm directly or indirectly will have mobility. And the mobility depends on where it is from. If it is coming from omentum, for example, or a transverse colon, something like that, it will move in all directions, up and down and side to side. And if it is coming from the mesentery, okay, it will move in an axis which is perpendicular to the axis of the mesentery. So the axis of the mesentery extends from, what is the axis of the mesentery? Left upper quadrant to right lower quadrant.
Yes.
Okay, tip of L2 to the right sacroiliac joint. So a mesenteric mass moves in a direction which is from the right upper quadrant to left lower quadrant, in a direction which is perpendicular to the axis, long axis of the mesentery. That is what is the theory. But I agree with you that in a given clinical situation, it is not easy to differentiate these. But it is important for you to know the basis under which people talk about the variations of different masses with, the mobility, variations in mobility of different masses.
Yes.
Okay, yeah. But clinically, if you ask me, can you guarantee that this is what it is? It is not possible. And there are many studies which show that the discrepancy between a clinician's assessment of a mass and that of an investigation like a CT, for example, are quite variable.
Yes.
Okay. All right.
Sir,
any other questions or
question,
comments?
sir.
Yeah, go on.
Sir, if you are done biopsy and if it is a METS, we consider it as a METS. there is any change in the procedure, I mean surgery, sir?
You tell me that again. You are the surgeon. Would you do anything else?
Sir, I doesn't know, but I'm
You know,
thinking if
guess,
it is a
man.
palliative.
There is no great rocket science in this. This patient has obstruction, right?
Yes, sir.
You have to relieve the obstruction. Even if there is
Yes, sir.
metastatic disease, you have to relieve obstruction.
Oh.
And that's what we did. So if the patient did not have nodes, okay,
Yes,
and was a patient in whom you could go for a potential cure, then the operation is different. You do a radical right hemicolectomy.
sir, even if it is a palliative, you will go for a right hemicolectomy, sir?
It is, but it is a conservative right hemicolectomy.
Okay.
It's a conservative right hemicolectomy, not a radical right hemicolectomy. And that's what we have done. We have done a conservative right hemicolectomy, which is a palliative procedure for this ill 75-year-old lady. I'm hoping that for the next few months or whatever, that she's alive, that she'll be able to eat well without vomiting and pain.
Okay. Yes.
All right. Okay. All right.
Thank you.
Good night.
Okay. Thank you, sir.
Thank you.